Next speaker will be Prof. Remo again. Prof. Remo, he is known as well in IBD field. His talk will be optimizing biological therapy in IBD.
Oh, you're going to start?
Yep.
So this is the original talk I was going to do. The talk that I gave before was going to be given by my colleague, Professor Ghosh. So it's not that I got invited twice to the same session. I was...
Is this long?
Yep, that's good.
Perfect.
Okay. Thank you. Okay. So I've been asked to talk about optimizing biologic therapy in IBD, and certainly I think that this is going to become very relevant in the next, at least in Saudi Arabia, I guess in the next year, and all over the world within the next several years as we have more and more biologics to treat from. So there's no doubt that from randomized controlled trials that the era of anti-TNF has been very successful. But regardless of the goals that we just spoke about, if you look at the performance within randomized controlled trials, only about a third of patients are truly well and meeting our goals at the end of 1 year. We need to remember, though, that randomized controlled trials are very artificial circumstances, both in the patients that go into randomized controlled trials, as well as the way we evaluate and treat, and some of the limitations within those trials. So I'm going to start by just looking at the definition of optimize or optimizing. And if you look at the definition in the dictionary, it means to make the most of, to use something to its best advantage, or to make it as perfect or effective as possible. So why don't we start there? So how do we make the most of a therapy? Well, it's about really balancing risks and benefits. That means ensuring safety, so what are the contraindications to that therapy? And in the case of anti-TNF, what's the proper pre-treatment evaluation? And I'll talk about vaccinations in that context. And it's about choosing the right patient. Who would benefit the most from going on a biologic? So what are some of the things that we should consider before starting? Obviously, I talk about biologic therapy quite often, but by no means am I saying that we should treat all patients with biologic therapy. In fact, if you look at population-based data, and I'm sure it's similar here within the kingdom, about half of the patients are going to do well, and about another half are going to need more aggressive or advanced medical therapy. Before we start, because for safety reasons, you want to do a detailed history and physical exam to determine if there are any contraindications to that therapy. This does include a vaccination history. You should obtain titers for different disease states, including MMR, varicella, HBV, and HIV serology in the appropriate clinical context. Baseline labs, you all know that we should do TB screening, and it really depends on your epidemiology on which you do as far as a TB skin test versus quantiferon gold. And I talked about sort of imaging in the previous talk, and before starting an anti-TNF, it's really to make sure that there's no sort of known or unknown sepsis either in the perianal region or intra-abdominally that can actually complicate the therapy and increase morbidity. Just a note on vaccinations, certainly most of our patients will end up being immunosuppressed. We know that this may lead to a decrease in the immune response. We also know that you can't give live vaccines. So this is really a process issue in optimizing therapy where you want to immunize the patients prior to starting therapy. And this should be either at diagnosis or when you first see them in consultation. There's several guides out there, including the ECHO guidelines, this guideline by Gil Melmid from Cedars-Sinai in Los Angeles, or you can develop your own guidelines and or processes, and this is what we do at the University of Calgary. There's an intake sheet. This sheet goes with the patient as well as going to their family doctor. So as others have mentioned, you can use this sort of in a multidisciplinary approach, but the important thing is to ensure that these patients do get vaccinated. Who should we treat? Well, one of the things that we need to look at are what are the absolute or relative contraindications to starting anti-TNF therapy in our patients. There's very few absolute contraindications. The first one, sensitivity to murine proteins, in the case of infliximab, is quite rare but does happen. I've talked about known active infection or sepsis, and an absolute contraindication would be advanced class 3 or class 4 congestive heart failure. There's a few relative contraindications, such as obstructive symptoms, but that's really in patients who have known fibrostenosis, patients who have demyelinating syndromes, especially centrally, and previous or current malignancy. I often get asked how many patients in a practice should be on an anti-TNF therapy. If you look conservatively, the number is about 20 to 25% if you're using a typical step up. We know that many of our patients will fail steroids, many will become steroid dependent, about 58% will fail steroids and azathioprine, and there's many, many other patients out there that over time we've decided that should be eligible for anti-TNF therapy or a biologic. In choosing a patient, I think it's very, very important to stratify and choose patients early that would benefit most. And this is a statement from ECHO. Patients who have clinical features that suggest a poor prognosis currently appear to be the most suitable patients for early introduction of thiopurines, methotrexate, and or anti-TNF. And certainly there's a lot of work that's going into choosing the patients who have a poor prognosis, and most of you have seen these type of lists before, both in Crohn's disease and ulcerative colitis, which for the majority of time we're relying on clinical factors that would put patients with Crohn's disease at risk for complicated or extensive surgery, or in ulcerative colitis would put them at risk for going on to colectomy and or development of dysplasia or colorectal cancer. However, I think going forward to optimize, we need to become a bit more sophisticated than that and relying on clinical parameters. And I think that this is just a snapshot on the way forward. This is some excellent work done by the group in Cambridge, in which they use gene expression signature from CD8 positive T cells to predict two different groups of inflammatory bowel disease. A high-risk group, which they defined as patients who would need to escalate early on to immunosuppression or would require surgery, and a low-risk group. And this performed in their hands much better than serological testing or looking at those low-risk or high-risk clinical parameters that I outlined in the previous slide. And to their credit, in 2016, they have a large trial that's being funded by the Wellcome Trust, and I think we await eagerly the results of this study to see if we can actually predict which patients would benefit most from early therapy. How about point number 2? How do we use something to its best advantage? This is all about treating early, treating the right phenotype, and the use of combination therapy. So I always try to explain to patients the importance of treating early. It's very similar to how you invest your money. So this is just an example of sort of what my father would have done in the old days, which he wouldn't have invested early, and what you can see is even though he starts investing late, he'll never reach the potential of my sister, who started putting $20 away when she was, say, 15 years old. So we need to invest as gastroenterologists in really unraveling why there are differences between early and late disease. And that includes trying to facilitate early diagnosis so we can get patients on therapy as early as possible and identify those patients who would benefit the most. And if we're talking about disease modification and optimizing biologic therapy, this is a key strategy. I've already shown you this slide because most of us do believe that there is an early window of opportunity. And it's been borne out in the clinical trial experience. As we've looked at clinical trials over the years with anti-TNF therapy, when we look at overall clinical remission, the trials that perform the best are in patients who have the least duration of disease. It was shown very nicely in the classic top-down versus step-up trial, where you can see that not only for the clinical endpoint that patients that received infliximab early did better early on, but more importantly, when we're talking about a treat-to-target approach, such as Mahmoud just spoke about, why at the end of 2 years, the proportion even though the proportion of patients were similar on infliximab, the patients who received the infliximab early had better as far as the hard target of mucosal healing than the patients who received it late. And we've also seen this in both the CHARM study and clinical remission on the left, where you can see in patients less than 2 years that they did better from a clinical standpoint, about 20% better than patients who had disease duration of greater than 5 years. But more puzzling is once again, if we look at mucosal healing in the EXTEND trial, that patients who had less disease duration did better as far as the endpoint of mucosal healing than in patients who had longer disease duration. Phenotype is also important, and this is data from our center where we asked a very simple question, which was, what was the phenotype of the patient, not historically, but when they started receiving their anti-TNF therapy? And you can see, if you look at B1 or a pure inflammatory phenotype, that the surgical-free, steroid-free remission rate in that patient population who received an anti-TNF was about 90%. That's a far cry from what we see in the clinical trials. As opposed, if you take all comers or patients who have a more aggressive phenotype, such as B2, stricturing disease, surely they do well early on in the first year, but they'll fall off and eventually require surgery. The other thing that we need to keep in mind when we're talking about treating an early disease is what is achievable in early versus late disease is much different. So even if we talked about endoscopic remission, but even if you're treating symptoms, if patients have advanced disease, late disease, you can only do so much even with your best therapies. Why combination therapy? So driving in from the airport, I saw a lot of this. I saw BMWs and Mercedes and Audis, and many of you may own an expensive car. Having a patient go on an anti-TNF is like buying an expensive car and then turning down the insurance policy. We know that insurance policies and or maintenance policies make cars run better and they make them last longer. And that's really the message of combination therapy. We know that if you use combination therapy, and this has already been shown, that patients do better. So this is data from Sonic, clearly demonstrating that patients on combination therapy did better than patients who are on infliximab alone. This is data from UC Success and ulcerative colitis showing similar findings. And even again, when we look at the hard endpoint of mucosal healing in both the UC Success trial and in the Sonic trial, you can see that the combination therapy is superior than monotherapy. We also know that combination therapy, this is allowing the anti-TNF to work longer, just like your car running longer. We know that it decreases immunogenicity when you use combination therapy. And this may be associated with the fact, may be due to the fact, I should say, that you can see higher trough levels in patients on combination therapy than on monotherapy. And even in the real-world experience, and this is the real-world experience with adalimumab, you can see in these 121 patients who were treated for infliximab for at least 1 year, with at least 6 months of combination therapy. They assessed their outcomes at every sort of 6-month semesters, not including the first 6 months. There was no difference if the patients were azathioprine naive or refractory at the start of infliximab, and they also looked at mucosal healing. And you can see that in patients who were on the combination of the immunomodulator, even in the beginning, similar to what Gerd has shown in his study, there was fewer IBD flares, there were fewer switches to another anti-TNF, the mean CRP was lower, and the cumulative dosing needs for infliximab was lower. And they also showed differences within mucosal healing. And I already showed the benefits of combination therapy as what were outlined in the REACT trial. But how do we make the drug as perfect or as effective as possible? This is really about the era of drug levels and therapeutic drug monitoring. We know that there's several studies that show a correlation between trough levels and efficacy in IBD, and they're outlined in this slide. And you can see, regardless if it's Crohn's disease or ulcerative colitis, regardless of what your outcome measure is, that we see that higher trough levels have been associated with positive outcomes. We see from SONIC, for example, I already showed the data on the left, but if you look at the quartile analysis if you look at the analysis on the right, you can see as the infliximab trough levels increased, the proportion of patients who achieved steroid-free remission also increased. And the slides are now stuck. Oh, there we go. Sorry. Similar to adalimumab, looking at mucosal healing, if you have higher levels, more patients will achieve mucosal healing. And it doesn't stop with anti-TNF. If you look at the data from the Gemini programs, you can see this quartile analysis that the percentage of patients responding to therapy increased as your drug levels increased. And this was true for response and a trend for remission. In ulcerative colitis, this is data from Cynthia Seo when she was at Mount Sinai before she joined our group. You can see that there was an increased chance of patients would be in remission and avoid colectomy if they had detectable trough levels. And similar when you look at data from Act 1, when you look at the quartile analysis, the proportion of patients in remission increases as drug levels increase. This is a retrospective look at sort of changing or doing some changes to maintain patients above a trough level of 5 from Adam Shivitz in Boston. And once again, if you look at the analysis which was done to see the probability of remaining on drug, if you dose optimize to trough levels, there's a higher probability that the patients will stay on drug. So when are we using this? We do it mostly when we optimize, when we want to optimize when patients are losing response. Ideally, we want to optimize primary response and maintenance therapy, and those trials, as I'll demonstrate, are ongoing. Could we optimize dose de-escalation as part of our optimization strategy? And I'll leave retreatment to later. So what do we do for loss of response in optimization? Certainly we want to make sure that the patients have a workup to ensure that they have some measure of inflammation causing their symptoms, and then we do therapeutic drug monitoring. If the trough levels are detectable and the endoscopy shows active inflammation, we'll switch to drug with a different mode of action, a non-anti-TNF. If they have detectable trough levels but the endoscopy shows no inflammation, then their symptoms are likely coming from something else. If their trough levels are undetectable and they have active inflammation and their antibodies are high, this usually means a switch within class. And if they have undetectable trough levels but low-level antibodies, you could probably still dose optimize these patients. What's the optimal window in the induction phase? It's really difficult to tell. We don't have very good data. There is a prospective trial called TAILORx, which is ongoing and may be close to full recruitment that may answer this question. And in the maintenance phase, at least from the Leuven group, it sounds like the optimal window is between 3 to 7 micrograms per mil, and this was what was used in the prospective TAXIT trial. So just a word on TAILORx. I think we're awaiting this. It's a randomized controlled trial evaluating tailored treatment with infliximab for active luminal Crohn's disease. It's a phase 4 trial. It's looking at both clinical and endoscopic outcomes after 1 year of treatment. It is a multi-center trial. This is the scheme that TAILORx is going to look at, and we eagerly await the results. There is another trial based on a subgroup analysis of the ULTRA data of adalimumab in ulcerative colitis, where once again you can see that with higher levels, it's associated with increased efficacy. And an ongoing trial called the SERENE ulcerative colitis trial is looking at not only standard dosing of adalimumab in ulcerative colitis, but high intense dosing where patients will be getting 160 milligrams weekly for the first 4 weeks, and then during the maintenance phase they'll be either randomized to 40 milligrams every other week, 40 milligrams weekly, or dose adjustments based on therapeutic drug monitoring. TAXIT was very informing. This was a look at patients with Crohn's disease or ulcerative colitis who were on infliximab maintenance therapy with sustained good trough levels, and it was shown that it showed better response and remission rates. There was more mucosal healing. So the TAXIT trial screened these patients, and the target was to optimize the trough levels between the magic 3 and 7. There was a control group after randomization where the treatment scheme was based on symptoms in the CRP, and an active group where they changed dosing based on therapeutic drug level, where the primary endpoint was at 1 year. I think most of what we learned during the TAXIT trial was during the optimization phase. So in the optimization phase, you can see in those patients who were dose escalated that the patients with Crohn's disease did better. In the patients with ulcerative colitis, there was no difference. There was also a decrease in the CRP. It also showed in patients who had elevated levels that you could dose de-escalate and not lose anything as far as the proportion of patients in clinical remission. And you can see that the mean concentration of CRP in the dose de-escalated patients also stayed the same. As far as the primary endpoint, there was no difference between the clinically based group and the level-based group, both in Crohn's disease and ulcerative colitis. So what were the conclusions as far as optimization? Dose optimization with infliximab based on trough level results resulted in a more efficient use of the drug and is cost effective. During the maintenance phase, when they were adjusting to trough levels, it was similar for continuous clinically based versus level-based dosing, but patients who were in the CB group were more likely to need rescue therapy. So the recommendations are to really dose optimize to achieve that level within 3 to 7 micrograms per mil, and to reevaluate possibly every 6 months. So in closing, how do we optimize biologic therapy in 2016? The first thing is work up patients prior to starting. This includes the disease state, disease burden, and ruling out contraindications, and make sure that you're treating predominantly inflammation. You want to treat early. You want to use combination therapy when possible. You want to use a treat-to-target approach, as Mahmoud showed you in the previous presentation. And we are in the era where TDM is going to be a vital part of our optimization strategies. Thank you very much.